Thank you very much. I will probably go pretty fast because most of the things I will cover has been covered. Um, so I want to thank Amber because, as you will see when I will talk about how we did the DEA, AAD, sorry, in Quebec. I'm not a corporate guy. When I get angry and pissed off, I'm pretty bad. And Hammer is the counteract that during the guidelines. So uh, I'm no have any relationship with that conference today. I'm not as Jim. I'm not an electrophysiologist. I'm not an interventional cardiologist. I'm not a specialist in echocardiography. I'm just trying to do preventive cardiology. I'm a bachelor degree in kinesiology that turned bad and then go into cardiology. So and all those stuff are for the guidelines that I'm involved with. So when you start guidelines, the definition of a consensus is majority of opinion, general agreement of concord, harmony reached by a group as a whole. Usually members disagree at first. So that's exactly what happened with what we did some last year, actually, because I started to think about that when the Canadian Academy of Sports and Exercise Medicine mandate ECG, and Andrew's there, mandate ECG in all the athletes. And I said, where's the science for that? So I said, okay, there's no science for that. So I called Andrew and I said, we should have something to write something about that because there's no science. And the title was from Stan Natel, actually. Stan Natel, give us this idea about the title. So we've been talking about that. Dr. Bagish nicely showed what happened in Italy when they screen and when you don't screen. But the rate is 55th patient over 25 years. And if you look at compared to the US, you've seen that when you screen those high-risk patients, you do good. The thing is, and I hope it will work. There you go. I just want to show you something that everybody knows. Okay, look at this one. Okay, he's been screened. Every screen that you can dream of has been, except probably MRI. Now we're feeling, and you can count from there. Okay, 6 seconds. How long it lasts for to have sudden death, right? So it's kind of so he fell down, and it just dropped dead on the field. So we all have this kind of story, no defibrillator, and that's those things happen, sadly. And that's what we were kind of striking for when we did it's not a guidelines, by the way, it's a position statement, because we didn't feel that the science was good enough to do a guidelines. So this is what happened, and Dr. Bagish talked about that. So the incidence of sudden death in long distance running, this has been alluded to. So I want to go fast because I want to talk about what happened in Quebec. But the thing is, if you're young, the chance of survival is pretty bad. And 2 weeks ago, there was a 24 years old guy with mild aortic stenosis who dropped dead in the Montreal Marathon. And I was told, but I was told that it took 25 minutes to have defibrillator. And we were talking about training. CPR was done by a resident of psychiatry. So it's kind of troublesome. So when you're young and you just falling from having a heart attack or something like that, it's pretty bad. So this is the thing that I was talking about when I talk about the what happened in Paris. So this is the event rate in Paris, and the case out there. Most frequent clinical presentation and resuscitation effort were successful in all but 2 cases. And it's underlying cardiovascular cause. And it's funny because 4 of those cases were smokers. Marathon runners were smokers. It's so funny because Guy Lafleur has smoked all his life. He was playing hockey and was smoking like a chimney, but he was feeling protected about that. Okay, so and coronary disease was there, and this is the main thing here. Half of these patients reported antecedent symptoms suggestive of ischemia. They all went into stress tests, and nothing was shown there. So and all usual, as always, it always happened at the finish line or almost the finish line. So what are the implications of ECG-based screening? Benefit of all large-scale screening is from mostly one Italian study that Dr. Bagish has been telling us. The difference between ESC and American Heart is there. And then I don't know if there's some news about that, but the only pediatrics association is the European one, and they recommend to incorporate ECG in pre-participation screening in athletes. So what is not debatable? Adding an ECG increases the diagnosis of several potentially dangerous disease. You know, those are the ones, the most frequent ones. So this is kind of not debatable. But what is debatable the other way is that adding an ECG does more good than harm, which when we did our position statement was not that clear. And Dr. Dorian was working at the time on his paper in the New England paper. So it's kind of modulate, you know, because we knew some, you know, you didn't tell us, but we knew about what's coming on. And the adding ECG saves lives over those saved by screening or other measure alone. This is debatable also. So the harm of the ECG could be inappropriate in a non-invasive or invasive study. Defibrillator in patient with hypertrophic cardiomyopathy, which was really an abnormal ECG and borderline LVH. Usually, one of my young colleague, I just review his grant proposal. Apical hypertrophic cardiomyopathy seems sometimes benign, but in Quebec, the founders that we found the genes, and there's a 26% death rate on those guys. So gene will probably provide more, you know, tease the difference in those patients. Could happen, could end with unnecessary ablation of accessory pathways, inappropriate athletic restriction without financial application. And probably Dr. Bagish is the best one here because he's working with professional athletes. And unnecessary anxiety that is hard to relieve. So what happened in real life? Despite the ongoing debate between American Heart and ESC concerning routine use of 12-lead ECG, the vast majority of professional sporting organizations in the States and Europe incorporate an ECG in their screening tools. So, and it's probably not that accurate, but you know, here is our Canadian one, and it was incorporate the physical history and ECGs incorporate into that one. So what this the Canadian Academy of Sports and Exercise Medicine did, I don't know when was that. I think it was 3-4 years ago. So they say that there's strong recommendation for national sport organization team to carry an automatic external defibrillator for travel and training with appropriation that all automatic external defibrillator cannot be available without training environment. You know, the soccer player that I just showed you. And strong recommendation that all national team athletes have a screening ECG. Frequency is not discussed and funding will be up to each team. So this is not working properly. I just want you to watch here and watch the guy legs. Hopefully it will work. Shit. Sorry. Doesn't work. Oh yeah. Okay. Look at that guy. Okay, just drop that. Boom, done. And then you know, he's ready to play. Wants to play again. So that's we call fast resuscitation, right? So I can, you know, I can send you that. I mean, it's very nice because it's provide the what we want to do here. Uh, so the is you've been. I think that Andrew showed you that slide. So when we did our position statement, we were pretty keen of having American and European um, reviewers because we knew at that time that we would put something together that will be not against all odds, but you know against other guidelines. And the limited scope was varsity and college athletes. And I, you know, I'm after that, you know, general practitioner are always asking me, could you give us a talk about post-stent, post-cabbage, or coronary artery disease stable patient, how to prescribe exercise, what should we do? So I think, quite frankly, that it's time to go further into that field also. So exactly what Andrew showed you, and I would probably that's the same. So ECG is not part of the blanket screening, nor are we prohibiting this. So it's part of the of could be one tool. The thing is, when we did that, we were struggling about big college program with a lot of money and a smaller college program with less money. So people with less money maybe will not be able to afford ECG and further screening. So we discriminate. And the other thing is in terms of age, you know, if you're 16 years old and you're Sidney Crosby and you're playing hockey at 16, you're not major, you're not, and right, you're still a very elite athletes. So we're struggling with those issues. So here you got weak to strong evidence and lower to higher quality of evidence. And it's kind of no-brainer that we need to have high quality emergency protocol. And I will talk to you about what is happening in what would happen in Quebec. And I hope that you will learn from those. I've been working with for the last 10 years with all the Ministry of Health talking about preventive cardiology. But it's and they were all rubber stamping that stuff, you know, yeah, we should do CPR, we should do this and that. But it's not the Ministry of Health who's taking care of that. It's the Ministry of Education. So 3 years ago, I was at a foundation raising event and the Ministry of Health was there. So I just attacked the guy and I said, you know, we need to do something because there was no CPR mandatory training into the curriculum of high school. And the luck I have is that guy at 17 did resuscitation just around a pool because it was a kind of a pool, I don't know in English, but lifeguard. So he said, yeah, Dr. Poirier, we should do that. Okay, so he went and he's got all those politically problem because you want to push the CPR into the curriculum, but who's going to do this? And there's some, you know, when you talk about government, it's kind of very strange. Let's put it this way: it's not, from my perspective, efficient, but you know. So there was a lawyer involved, and they just did that. So they put CPR mandatory in high school at the ninth grade. So it's in the curriculum. It will not disappear. But I asked the guy, what about AED? He said, there was no money. I have pushed so hard, da 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 da. I said, okay, I will take care of it. I need a resource that will give me all the name of the director, phone number, and email of all high school in the province of Quebec. Okay, so that resource was pretty efficient. And we and sorry about the Art Foundation, but I didn't know what Art Foundation were. for example. So we work with the ACT Foundation. So the ACT Foundation call every school to know which school have or has not AED. And then I asked the physician in Quebec to pay for the AED with a tax deduction. So we got a price of 1,500 per defibrillator, and they had a tax deduction. In my place, we got 10 cardiac surgeons and 38 cardiologists, and we all paid for one. So we start the stuff with 40 something defibrillator, and so we cover all the east of the province. And the thing that was another challenge is who's going to taking care of the defibrillator in the school, because the ACT Foundation cannot do that by themselves. So we invent a contract between the Ministry of Education and the school, signed by the school. So if there's upgrade, the school receives the upgrade, okay? And the school has to do the maintenance and do the training. The money for the training come from other source, but they are obliged to do that. So that's what we did, and we succeed. It will be announced, this fall, and people are pushing me to do the primary school. There's 1,900 primary school in Quebec. So if I do primary school, the thing first is to put CPR mandatory at 6th grade, because if you do CPR mandatory at 6th grade, you can be evaluated again at 9th grade after every 3 years. So you've been doing this at least 2 times in your life. So in 10 years, you will have a generation that will be able to resuscitate everybody with a DA anywhere. This is the goal. But the thing is, this government right now, I've got 3 years to do that because this government is pretty difficult to get in. So the best way I got in is through reporters. When when I'm interviewed on TV, in radio, and I got pissed off, then they challenge me. And those guys, I don't know how they do that, but those reporters can get you the right person in any government. It's pretty amazing. So we should use that. And so the thing is, we should have resources. You should have resources in each Ministry of Education that would provide you with names and schools and stuff. And then maybe not, but that's the way we did that. And the thing is, there's a 1,900 physician in Canada, in Quebec. So for me, was kind of a no-brainer, and at the end, we need 166 physicians to buy one defibrillator. And I've earned them all. We were talking about, don't put defibrillator in high school because it's not cost effective. And I was again pissed off. And so I went on TV and I said, it's more, you need to broaden the scope of that, because I've got a patient that I use sometimes. So at 58, he dropped dead during a badminton play in high school, because those are community sports facilities, right? So you need that to be available, but he's a survival without any sequela. So you need to broaden the scope of that. And I do know that the Heart and Stroke in Quebec are working with the community and private and arena and all those things. So I do think that the timing is pretty good in pushing the envelope. I would say when we were talking at the end that, and it's funny because I'm using the same phrase, one size doesn't fit all, but I do think that VEA or EAD should be widespread, and training should be widespread. And if you train, and if it's mandatory at school level, then we'll probably be in 10 years in good shape, because will be a no-brainer, like the peanut in the plane. So thank you very much. That's what we try to do thing. But the thing is, it took me 10 years, and I used François Philippon, who is an electrophysiologist, because the network of electrophysiologists in Canada are pretty tight, and those people work together pretty nicely. And I do think the way we work is I was the bad guy and Francois was the good guy, corporate guy, and say, oh, Paul doesn't mean that really, and this and that. So I was kind of, breaking the door, and the thing, that's the way I work usually. But, I don't know how we should do that, but I think we should go forward.